It's 11:03, Dr. Payne Show. The sun is out. It's beautiful. It's Saturday. Get out there and use your body and exercise and move, because movement's key. Sitting around doesn't do sweet FA. We know that, right? That's the worst thing you can do for any sort of physical problem. Well, generally, unless you can't move. But
and it generally obviously depends. But in general, the chronic aches and pains are not the things you should be sitting around, moping around, and not doing anything. Those are absolutely the ones you should be moving around and doing things. Now, obviously, if you have an acute ankle sprain, you're playing basketball yesterday, you roll your ankle, well, you shouldn't be moving that around today.
Yep. So, like our pal Courtney are.
You got an ankle
sprain? She's got a bad ankle. You've had that for a long time, and you're young.
Yeah. Well, yeah. In January, I rolled my ankle in Cuba, and it just has not gone down in swelling.
Yeah, most people that I meet that roll their ankles in Cuba, there was alcohol involved, I bet.
I was going to say you should be rolling something else in Cuba when you're kicking it, man, not ankles.
I mean, once you start rolling your ankle, the unfortunate reality is the ATFL, which is one of the ligaments there that holds the ankle, I guess, to the leg.
It's easy to roll again?
Yeah, well, you start to lose. So every time you sprain it, anytime you sprain a ligament, it loses a certain degree of its strength, and it starts to become more and more elastic. And so people that have chronic ankle sprains, it's often due to a very weak ATFL. And because you have that ATFL, you just have excessive movement in that foot. And so you essentially end up, rolling your ankle more often. And so once you roll your ankle once, you're more likely to do it again and again and again. And so obviously rehabilitation is very, very important in terms of looking at the other muscular structures that you can make stronger that would do the same actions, such as tibialis anterior, for example. And also, people who are athletes, maybe wearing bracing while you're in your activity is important for stabilization. Later on in life, there's the potential of fusion, but getting it fused is not an ideal thing when you're younger, because you're going to lose mobility in other areas naturally from fusing a certain segment. But very, very common. And I mean, in terms of short term, when it happens, obviously, ice, rest, pressure, elevation, those are the big things, because the ankle will often swell. Does your ankle swell, Courtney?
It was. I remember it was really puffy at one time.
It was awful, but when I go to the gym and after I run, it gets pretty swollen.
Oh, it does all, yeah.
Yeah.
How many times have you sprained your ankle?
Well, I've broken it 3 times.
Oh, wow.
And then sprained it twice.
Yeah. Okay. Yeah, so that's you got some rehab to do.
A little bit,
yeah,
right?
A little bit. You got to catch up on all that. But yeah, absolutely. Very, very important, the rehabilitation. I mean, we were just talking with Greg about that with his knee reconstruction, the ACL, and how important that is. And I mean, he was very surprised about how many people don't do the active component of their care. I'm no longer surprised, because I see it all the time. Yeah. But I mean, the reality about what I do is I'm very honest with people. So when I do see people that aren't following through with their prescribed treatment, whatever that may be, I just am honest with them, right? You can't expect to get what you want to get out of something if you're not putting in what you need to put in. And the thing about physical medicine in general is that it requires an active component and requires some type of involvement on your part. Mm-hmm. And if you're not doing that active component, well, then your outcomes are going to be minimized. Your prognosis is not going to be there. You may very well, like even in Greg's case, he even if he did nothing, he would likely start to feel better. But what happens later on, and this is where we get, people who come in and say, yeah, I had this type of injury and I did this and I never really rehabbed it properly. And we had a couple callers last week who were, saying similar types of things, that they never really did the proper rehabilitation. I had a patient call me this week, had Cauda-Equina syndrome back in the 90s, had to have emergency back surgery, obviously. And, he's kind of done the passive things, chiro, physio here and there, massage when it's aggravated, but never really done a good structured program of rehab. And I said to him, well, why not? And he said, because no one's ever really mentioned it. And this is a big thing. I mean, we were speaking with Greg about how important it is for the patient to be involved in their care. But equally so, there's a lot of clinics out there that aren't making that part of the program, right? Because doing that stuff is hard. It takes time with people, and it's much easier to slap a machine on a person, walk away, and leave them there. Yeah. And I mean, there's a time and a place for that type of modality and that type of treatment intervention as well. But in general, you do need to also have that active component, and a lot of places aren't recommending that stuff. And so it's very, very important that you're going to reputable places as well, because if you're not going to get the right treatment. And if you don't get the right treatment, I mean, it's not the average person's job to know how to rehabilitate after an injury or after surgery. That's why you're going to see the professional. So very, very important. And, obviously anybody that's listening, if you've just had surgery or have sustained an injury, and even if you are going somewhere and you just want to have a conversation about what the right things that you should be doing are, I'm happy to answer those questions. There's, even like with Greg, he was going somewhere else. I didn't ask him to come to one of my clinics. It sounded like everything that was happening in the right way, and that's all that matters.
The phone lines are open, as you know, 416-870-6400 *640 on cell. You have pain concerns, rehab concerns, anything to do with your person. Bring it on. Dr. Lou's here to answer those questions. Outside of show hours, 1-855-55-Dr. Lou, DRLOU, and info@paincarecanada.com. We'll get back to the Dr. Payne Show right here, Global News Radio, 640 Toronto. It is 11:13. Yeah, plenty of time to call in, 416-870-6400 *640 on your cell. David, first up, how are you, pal?
Good morning to you both. Thank you for taking my call.
No worries.
I listen to you every Saturday, and
thank you.
It's pretty good. Of course, I listen to Craig first to get my morning chuckle, and then
now the serious stuff.
And then the serious stuff.
That's it.
Yeah. That's right. Yeah. Let's put it this way: I'm 63, going to be 64 coming up next month.
Yep.
Been active in sports and hockey, football, baseball, that nonsense when I was a youth. And now both my big toes, the large bone before it becomes your toe,
yep,
both of them are, you can see some redness and swelling. I've gone to the doctor. The last thing in the world you want to do as a human being is Google your ailment.
Yeah.
It scares the hell out of you. So it's not a bunion. It's not gout. I've had my uric acid checked and everything else. It's nothing like that. He calls it a calcification of the bone because the bones have been broken a number of times. It's built up a calcium. The pain is just, sometimes it's throbbing. There's every now and then when I squat, it'll crack, and that provides some relief, but I'm sure I'm doing more damage to it every time I do that. And I'm just wondering, he told me there's an operation, but he says you don't want it. It's more painful than what you got right now.
Yeah, I mean, so yeah, right off the bat, anytime. So that is a big area in terms of where osteoarthritis can set in, which is what calcification is. That's all he's saying, is that you have significant arthritis in that joint, which if you do, it tends to be, very, very painful. Anything once it becomes bone on bone is going to be painful. Right. And that's essentially why when it cracks, it feels better, because there's a gap in that joint, and that provides some temporary relief for you. In terms of, anytime something is bilateral and symmetric, meaning on both sides and in the same area, I always like to rule out anything autoimmune. Now, in your age group and as a male, it's limited to how many things would be autoimmune that would cause that. So that's low on the list for you, but nothing is ever impossible. Your doctor likely did do some blood work. Obviously, anything in the big toe, you want to look at gout for sure. But if your uric acid levels are normal, then obviously it's not gout, which is good that was ruled out. And that leaves us pretty much with the mechanical osteoarthritis type of pain. And so, the question becomes, what do you do for that? And really the answer is pretty tough, because, you could do a lot of conservative types of interventions, whether it's therapy, bracing, different types of exercises, and all of that will provide, some temporary relief, I guess, maybe at best medication. And then, there's the option of surgery. It's always, again, in the foot, the one thing that I can tell you is when you go in and intervene on the foot from a surgical standpoint, you often end up losing mobility in other areas. And so because there's so many little joints in the foot, like if we broke it down, it's not like when we look at the leg and it's like, well, there's just the knee joint, right? There's a lot of little joints in the foot and in the hand, right. Actually the same kind of thing. And so once you start screwing around with one joint, well, then other problems tend to develop. So, I often like to advise that if you can do the conservative things and control your pain in that way, for as long as you possibly can, I think that's probably a better option. And then once it gets to the point where it's not controllable with those things anymore, then maybe surgery is the option. But again, with surgery, I think the best thing to do is always go get that surgical consultation. Now, what I mean by that is you can still go see that surgeon, right? So if your doctor says there's a surgery for that, I would say, okay, well, send me to see a surgeon. Let me speak to them and let me find out just the pros and cons. And because the surgeon is going to know the most about that type of surgery, right? Me, your family doctor, we're going to give you the general things about it. But a surgeon is going to be the one that really is going to provide you with the best answer in terms of what to expect from that. And, sometimes I tell people and then get a second surgical opinion, right, from two surgeons and see if those opinions coincide and correlate, or are they totally different? Because if they're totally different, then that should raise some red flags for you because, why? Why would they be that different? Right. And so right. I would say that that's the best option. I mean, in general, I obviously can't comment on exactly what it is or what the best way to treat it is unless I see you. So if you're interested in an assessment, that's another good option for you is come in, have an assessment, and let's take a look at it. But there's a couple things there to consider, obviously, but it probably, in my opinion, sounds more osteoarthritic due to other injuries, and it's just simple. I shouldn't say simple. I should say mechanical osteoarthritis.
Now, are there any types of topical treatments that you can put? I mean, there's no muscle really in that foot area, so, topical treatments for pain and muscular aches, I can understand it, maybe heat penetration and that, but, soaking your feet in Epsom salts, stuff like that.
Yeah, the big thing to try to figure out is your pain inflammatory in nature. So often with osteoarthritis, it's painful because as the bone starts to touch bone, there's inflammatory reactions that happen, and there's inflammation happening there. So and again, I don't know because I haven't looked at your foot, but if that was the case and there's inflammation, then I would say some type of anti-inflammatory cream is a good idea, like a Voltaren, which has diclofenac in it. Or you can go more natural versions of the cream that don't have the medical grade stuff like Trauma Care might be an option. But again, it depends if there is true inflammation going on.
Okay, I appreciate it. Thank you.
No problem.
Thank you, David. You need to follow up, 1-855-55 Dr. Lou, DRLOU. Email as well, info@paincarecanada.com. Still got plenty of time for your calls. I see you there, Stephen. We'll get to you and you as well, 416-870-6400, star 640 on sale. Dr. Payne Show, Global News Radio, 640 Toronto. Yeah, you can call that number. Still have plenty of time to call in, ask your questions, get some answers, move on from there. Stephen, thanks for hanging in, fella. How are you?
Good. Thanks for taking my call.
No worries.
Dr. Lou, so I'm a trainer, but one of the biggest questions I have, and a lot of people, is when do you go to emergency for a sprain or something like that to find out if it's broken or not, right? Because if somebody falls down the stairs, really bad sprained ankle, right?
Yeah.
It's already inflammatory. It's already bruising. They can't walk on it, but you're putting ice, compression, elevation on it. So where's the fine line? Because my wife broke her elbow a couple of years ago, waited a couple of days, went in, found out that it was broken. It wasn't sprained.
Right. Yeah. So
when's that?
Yeah. So I would say in general, what I would say is that oftentimes, like even if something is, how do I put this? So even if something is, it's a good question. I like the question. I'm actually trying to think of the way to answer. I have the answer in my head. I'm just trying to figure out how to get it out. So let's start with the things that would be an absolute emergency so if you fall, so when we look at what's called the auto ankle rules, for example, which is the guidelines that we would use for taking an x-ray when we think an x-ray should be taken, things like if there's trauma, anytime there's trauma, that's like usually an indication that, you got to have an x-ray on that. Now, does that mean that that is an emergency, that you should be going to an emergency room, or can you wait till the next morning? That's kind of, and I think that's what you're asking, where is that fine line?
Right?
Yeah. So
because I don't want to send somebody into emerge and have 8 hours versus going into a clinic having the doctor say, "Oh, go get an X-ray." They go in, they go to
exactly.
the clinic.
Yeah. So I would say in general, the things that would be an absolute emergency is obviously if there's a visible deformity. So, you know, sometimes people break their leg and you can actually see that the bone has shifted, you know, and other times you'll have fractures that is just like a hairline fracture. Well, that's not an emergency because it's stable. It's what we would call a stable fracture.
Right. Mm-hmm.
So anytime there's some type of visual deformity, absolutely 911. If there's obviously bleeding, an open wound, that would be another reason, just because of the risk of infection. The other big thing would be is if you start to get any type of paresthesia, so altered sensation. So if you you fall, you roll your ankle, and all of a sudden your whole foot starts going numb, or you start losing motor control, any type of neurological symptoms, that's an emergency too, because maybe the fall or the trauma or whatever maybe severed the nerve or affected the nerve, and so that needs to be dealt with immediately. And so I would say those are probably the 3 or 4 things that I would say are an absolute emergency, where if you've sustained that, go. If it's kind of like what Courtney did in Cuba and you roll your ankle, it gets a little bit swollen, those are the things that I think you could probably manage and go. You still should get it checked out, but you don't necessarily have to go clog an emergency room with that type of visit.
Because you'll get sore throats and mild fevers, and they're all over the emergency room.
Yeah, exactly. And so, and that's what...
I don't want to bog them down, because that's the last thing they need over there.
Yeah, so I would say those are probably the big things. Any type of visible deformity, any type of open wound, any type of neurological compromise where someone's complaining of like severe numbness or severe pins and needles or loss of motor function. And I would say maybe even if the swelling is beyond what you would expect. So like, you know, Courtney just showed us a picture of her ankle and it was pretty swollen, but it's not very bruised. So if something is like swollen and extremely bruised, and the bruising is going all the way into the foot, and those things, that there might be a lot of blood that's accumulating there. And again, that may be putting pressure on nerves and things like that. That needs to be dealt with. So I would say those are the 4 big things where, you'd probably want to tell somebody, head to an emergency room.
All right. Perfect.
Okay.
Thank you very much.
No problem.
Appreciate it.
Thanks, Stephen. Appreciate that. And what's the one you keep mentioning about the back?
Cauda equina.
Yeah. Why?
So oftentimes people that have disc herniations, cauda equina syndrome. So the spinal cord, when you look at the anatomy, the spinal cord, so you have your brain, then you have the brainstem, and then your spinal cord starts. Around T11, T12, your spinal cord actually ends, and it becomes the cauda equina, which means horse's tails. So in the spinal cord, all of the nerve fibers are concentrated into a cord, kind of like, you know, a wire or something like that. And then after T11, T12, it separates into a whole bunch of little nerve roots.
Like
and
guitar strings.
It looks like a horse's tail. That's why it's called the cauda equina. It's Latin for horse's tail. Cauda equina syndrome is people that have some type of disc pathology. So when we look, so the disc can either inflame, right? It can bulge, it can herniate, or it can sequester. A sequester means when the jelly actually falls in to the spinal canal.
Wow.
So anything that puts severe pressure on the cauda equina is going to cause certain types of symptoms, the most serious ones being bowel bladder dysfunction. So you are unable to control your bowel bladder function. That's an absolute medical emergency.
Really,
and it's something anyone with a disc herniation needs to be aware of. Very low chance, but you need to be aware, because if you feel bowel bladder symptoms, you got to get emergency surgery to get the pressure off the nerves, or it becomes permanent.
Short break and your phone calls. Lines open, 416-870-6400 star 640 on cell. Dr. Payne Show continues. Global News Radio, 640 Toronto. And 11:32 till 12 o'clock, Dr. Payne Show, 416-870-6400 star 640 on cell. That was a good lead in that last call. Simple things leading to a quick jaunt to the emergency room.
Yeah, that's actually good. Like and I think it's probably a good thing to have a conversation about what things would warrant you, like what would seem like simple issues, simple musculoskeletal issues, what things would warrant an emergency visit. And so then we started at the ankle. Now the extremity, the arm would be kind of similar in that sense, right? So any type of onset of sudden paresthesia after trauma or visible deformity are things that we talked about. Cauda equina syndrome in the low back. With neck pain, you know, something that I guess we should bring up. So stroke is a big thing. Okay. So neck pain, one of the initial symptoms of a stroke can be a headache and neck pain. And so a lot of people are unable to distinguish, is this the same type of headache that I've had my whole life that I get, or am I all of a sudden stroking out? Yeah, exactly. So there's a couple things there. Number one, people that have some type of brain hemorrhage will obviously complain of a headache because there's hemorrhaging going on in your brain. But what they'll characteristically say is the worst headache of my life. So if all of a sudden you are experiencing the worst headache that you've ever had in your life, that should start to raise red flags. The other thing that should raise red flags is stroke is essentially some type of blood blockage to the brain. So any type of neurological symptoms, especially on one side of your body. So if all of a sudden you start to slur your speech, or your face droops, or you start drooling out of nowhere, or your one eye goes blurry or blind totally, or you start to get sudden numbness on one side of your body, or sudden weakness on one side of your body. Those are all things that if you thought it was just a normal headache, it's not. That warrants an emergency medical a 911 call, because it could be a stroke in progress. And now with anyone with cerebral vascular or cardiovascular issues, when you call 911, they'll often advise that if the person is conscious, that they should be chewing on an aspirin? Because the nitroglycerin will actually help to dilate the vessels to help blood flow. So that is a big, big thing. So even for yourself, if all of a sudden you think something is going on, as long as you're able to safely chew an aspirin.
Keep some aspirin
so
handy.
I think aspirin should be handy in everybody's household, because it can really be the difference if you're sustaining some type of cerebrovascular or cardiovascular event.
416-870-6400 star 640 on your cell. Ray, good morning.
Good morning, Doctor. About a month ago, I'm not sure if it was how you get a kink in your neck and you do the stretch and the kink will pop.
Yep.
Or I banged my head on a low door about a month ago, top of my head. But since then, I've been getting a ringing in my head, like a ringing, not a buzzing, but like a ringing.
Yeah, like a tinnitus. Okay.
And I had a CAT scan.
Good.
Had blood work done, and they didn't see anything.
Good.
And it's not constant. If I go on a bike ride and maybe an hour into the bike ride, it'll start ringing again.
Mm-hmm.
And then it'll subside in about an hour, and then it'll come back.
Yeah. So one of the things, if someone said ringing, again, this is one of those things where I'd start at what are the more serious causes, right? Did you have some type of cerebrovascular event? Is there some type of growth in the brain somewhere? Now, obviously, you've already had all that ruled out, and so that's very good. One of the things is there's actually certain muscles in the neck, and they actually tend to be the muscles in the front of the neck versus the back of the neck, so towards the throat. So the bigger muscle, the SCM, can actually radiate. So we've talked about myofascial pain before, which is pain that radiates into different areas. There's a couple trigger points, interestingly enough, and I actually learned this not too long ago from a massage therapist that I work with, and then looked up some research on it, and it's really, really interesting. There's a couple muscles that if you have, for example, like a trap trigger point and you push on it, people will feel pain into like their forehead, for example. Well, there's a spot on the SCM, which is a muscle that when you push on it, people will hear ringing in their ears.
Wow, really?
Yeah, and so, Ray, again, I would have to assess you to make sure of all these things, but sometimes it's something to consider. Sometimes these serious types of symptoms can also just be muscular, right? So even there's something called cervicogenic angina. So people who have sudden chest pain that they think it might be their heart muscle, it can actually be related to the muscles in the neck and the different nerves that go down that way. And so we call it cervicogenic angina. Now, obviously, if you're sustaining chest discomfort, the more serious thing to rule out first is actual angina or some type of myocardial infarction or myocardial event. So obviously, this stuff needs to be done in a certain progressive order, which is sort of what you've already done, Ray, where you're ruling out the more serious things. Could also be an inner ear issue that is causing that tinnitus. So that's not necessarily an emergency, but the crystals within your inner ear might have maybe shifted with some of the things that you did, and that may be creating an issue. But those are all things that can very easily be assessed clinically. So I would say come on into the office for an assessment, and let's try to figure out what it is.
Yeah, so I'm waiting for my referral for an audiologist.
Okay, yeah, that's good.
Where they'll test like the different ringing of different sounds to see what my range is.
Yep. But even so even then, I would say you can come in before that. Like, I mean, that's great. But again, there's a couple simple tests that we can do that'll start to tip us off. And like anything, the sooner you get it treated, the better.
Very good. Thank you very much.
No problem.
Thank you, Ray. That number again, 1-855-55 Dr. Lou, DRLOU, and info@paincarecanada.com. More of your phone calls back to it, Adam. I see you hanging on there, and you have time as well, 416-870-6400, star 640 on cell. Dr. Payne Show, Global News Radio, 640 Toronto. 11:42 Saturday morning, a lovely weekend, and plenty of time for you to call in, get some questions answered. 416-870-6400, star 640 on cell. Dr. Lou here to answer them and send you down the right path. Adam, thanks for hanging on, pal. How are you?
I'm very good today. How are you guys?
Good, sir. Good. What's going on with you?
Well, I just caught the tail end of a discussion with herniated discs.
Mm-hmm.
Yep.
And one of my problems, and I was in a car accident about 8 years ago, and I herniated like 8 or 10 discs, and it's really bad. And but I have a problem now with my bladder. I've always had it, like ever since, like within 6 months after the accident, I started to have uncontrollable actions with my bladder.
Okay.
And basically, they kind of just, well, it's your age, other reasons. They never really, because they said if I had a problem with having a problem with having a number 2 or whatever, then that would be an issue. But they never thought it was important with the bladder.
Mm-hmm.
And I heard you discuss it, and I went, that sounds like me.
Yeah, it would be. It's a pretty progressive thing that gets worse. It doesn't often stabilize on its own. So just by the very nature that it's kind of like, stop for you. I don't know if it was necessarily that. It may just be coincidental. Or maybe it was mild and they never caught it, but you'd see that on MRI, and obviously if you have that many disc herniations, they must have taken an MRI, right, or some type of CT scan, and then you'd catch a Cauda equina syndrome on imaging.
Yeah, no, I've done all of that. Like I've had probably 5 MRIs at least. Mm-hmm. And they just didn't seem as interested in my bladder problem. And it's a major problem. Like any outings, driving a car, like I get like a 5-minute warning if I'm lucky.
Yeah. Again, it's a little bit different the way Cauda equina syndrome presents. Could it have been? I don't know. I mean, at this point, whether it was or wasn't, the important thing is that if it was, for example, whatever you have is permanent. Like there's no real way to reverse it. Have you seen a urologist about your issues?
No.
Yeah,
no,
so I would just ask your family doctor to refer you to a urologist and get that.
Okay. No, I just thought there was more information on it, and I appreciate it. It was a great show.
No problem.
Oh, thanks, Adam. Appreciate that follow-up. If you need to, 1-855-55 Dr. Lou, DRLOU. Move on to Dan. Hey, Dan.
Hi there. How are you?
Good, pal. What's going on?
Good. I called you guys a couple of months ago. It was with regards to a Baker cyst that I had for about a year at the back of my knee. You told me to sort of wait it out, see if it wasn't giving me any problems, which it wasn't.
Mm-hmm.
Of course, within a month or two of calling you, it started getting bigger. I also felt additional pain in the middle of the knee, and it's gotten quite large. So I went to see an orthopedic surgeon. He recommended we drain it. We did drain it. And within a week, it was back again, pretty much the same size, same symptoms.
Yep.
My thinking is, just because I've had torn meniscus before, is that it's feeling very similar to the torn meniscus, which I'm wondering if that would cause the fluid. He wants to drain it a second time. I'm kind of curious what you think.
So, I mean, if you've had a torn meniscus before, oftentimes the Baker cyst developed due to degeneration within the knee. And because the fluid is seeping out. So you might just have a degenerative meniscus because of the previous things going on. And so, yeah, I mean, have you had an MRI of your knee?
No, we haven't had that yet.
Yeah, I would say, get it drained again, obviously, if the fluid is building up. But I would say probably getting some, good high-quality imaging like an MRI at this point is probably not a bad idea.
Okay.
Okay?
All right. Yeah, thank you.
No problem.
Appreciate that, Dan. Again, 1-855-55 Dr. Lou, DRLOU, info@paincarecanada.com. Describe the consultation, because we talk about that and you say, give me a call and go from there.
Very, very simple. Give me a call, 1-855-55 Dr. Lou. You're going to leave me a message. I'm going to call you back. I will be calling you back from the 855 number. So if you see that, answer that. And we're just going to have a conversation about whatever the issue is. Usually, I would say on average takes about 10 minutes. Depending on your issue, maybe it's a little bit longer or a little bit less, but there's no rush on my end. And we just essentially have a conversation. And, if I think that it's something that I should assess, if you're interested in my assessment, I'll make that recommendation. Equally so, sometimes things like this is a perfect example. I'll just say, go back and get an MRI. There's nothing that I'm going to be able to add to what you're doing right now. And other people call me with things that are totally unrelated to the things that I particularly treat. And I just basically try to advise them on, going back to their family doctor or whoever their primary healthcare provider is. Just sometimes I can even help people formulate their words, right? Because a lot of people don't know how to describe their issues, those types of things. And it's free. So it's a free phone call that you're going to have with me and about your issues. My expertise being the musculoskeletal pain. So obviously those, I think, are the better things to call me about. And the other things, obviously, I'm going to know the extent of knowledge that I'm going to know from learning it, but it's not something that I practice every day. So if you're calling me with urinary issues, or I've had people call me with even cancer-related issues. Not my specialty. I'm often just going to send you back to whoever your specialist is.
We'll take one more small break here and get back to the last few minutes, which means you still have time. If you want to ask a question, call in 416-870-6400, star 640 on cell. Dr. Payne Show, Global News Radio, 640 Toronto. If we have time, we'll get through an email or two, but before that, always, Alan, hello. Thanks for calling in, Alan. How are you?
I'm good, and you?
Good. What's going on with you today?
About 2.5 years ago, I jumped off a cliff and into water and landed badly and did a burst fracture of the T10 vertebra. And it's healed up pretty well. It looked really ugly on an MRI when eventually I got one done, and it was very painful for a long time. But it's healed completely now. And my question is it likely to come back at me in later times?
I hate to answer it this way, but I would say that the odds are against you. That, anytime you've had that significant of an injury, the way that is now going to degenerate is going to be much. This is where degenerative disc disease matters in instances like this, where that area is likely going to degenerate much quicker than any other area that hasn't gone through that. So, I almost don't like telling people that because you're kind of expecting it, but I also don't want to lie to you. So is it something that could rear its head? Yeah. Is it likely? Probably. How old are you?
67.
Oh, 60. Okay. Yeah. Degenerative changes don't happen overnight. They do take time. So I would be more concerned if you were 37. I think you kind of got to, unfortunately, take it day by day. I would recommend the biggest thing that you can do is really build a good, strong core with rehabilitation. Just in the instance that does become significant enough to start causing pain, you at least have a strong core. And that's really, if you have a strong core, then really you can have as much degeneration as possible. It tends to eliminate or minimize the amount of pain. So I would say that's probably your best bet. And obviously don't jump off any more cliffs.
People said...
Sorry?
What the hell are you doing that for? Well, you know what? I'm not doing it anymore.
Yeah. No, I figured that much. But I would say, in general, that it's something that I think you should be doing good core rehabilitation for, just so that it keeps that area stable and minimizes any type of exacerbations or pain that area might cause in the future.
I have no issues with it at all at the moment. I have no pain. I was really concerned about pulling and dragging last year. I ride a motorcycle fairly consistently, and putting it up in the center stand was something I thought was going to be a problem because it creates a lot of pressure on your spine.
I'd say be proactive about it, though. Rehab is not, doing exercises for your back is not going to be harmful. So, you got nothing to lose. I think the best thing you could be doing right now is good rehabilitation of your core.
Alan, appreciate that call. Any further discussion, 1-855-55 Dr. Lou, DRLOU would be the way. That's one of those weird circumstances, whereas Alan, being rather a younger guy, being an older gentleman, time's actually on his side if he's worried about degeneration. I mean, like you said, if he was 25, then it's like, oh boy.
Even significant degeneration happens quicker, but it doesn't happen overnight. Now, right. Again, I think it's great that he doesn't have an issue with it. But again, and I think when it comes to low back injuries, the answer really, it can almost be anything. You got to do good rehabilitation. Yeah. The spine is just that way. You got to rehabilitate it. And if you can rehabilitate it the proper way, it really, really tends to minimize. And the best outcomes, the best patients that I've seen that have done the best with their chronic back or spine issues is really with rehabilitation.
Right.
Yeah.
You got an email? Go for it.
I do. And it's actually related to some type of trauma as well. So this person writes, after 2 serious falls, both in different years in my 50s and for different reasons, I had been diagnosed with a scoliosis, which I had never had before. Can a fall or an uneven surface where the upper body is 6 to 8 inches higher than the lower body do this? So I guess the question becomes, can trauma create scoliosis? My answer to that is, if it was related to the trauma, it would be related to fractures of the spine. The radiologist would have seen that. So whoever saw the x-rays would have commented that because we can see, or a radiologist can see fractures and tell you, is this new or is this something that's old? And so, the reality is here that it depends on what was seen in the x-ray or the CAT scan or whatever they did. Were there fractures that were relatively new after these falls? And obviously, if you have some type of fracture on one side of the vertebrae, it can create a scoliosis. The other thing is, she maybe had a scoliosis her whole life and just didn't know it, right? And so that's the big thing. Or maybe she did know she didn't have a scoliosis, and all of a sudden, like she's writing, maybe she does. So I guess it really, really depends. I'd have to see the images and see the radiology report to see, was it commented that this was a new fracture, and that fracture led to changes in the shape of the spine, which is possible. It would be a traumatic scoliosis.
Yeah, that seems kind of weird, just to have something like, as opposed to not being born with it or whatever. Right?
Yeah, but again, there would be telltale signs in the imaging that would tell us that this is related to trauma. Yeah, it's not something that would just happen and there'd be no signs that we'd be able to observe. So, I don't know. I'd have to see it in order to be sure. But, a lot of falls can lead to compression fractures in the spine, and those compression fractures can change the way your spine curves, for sure.
It's been another eventful hour, and thank you for all your phone calls. Thank you, Dusty. Thank you, Courtney. And moving forward, want to get a hold of Dr. Lou, simple, 1-855-55 Dr. Lou, DRLOU, info@paincarecanada.com. Till next time, Dr. Payne Show, Global News Radio, 640 Toronto.